Hi everyone, today I'll be talking to you about everyone's favorite subject, prostate biopsies. I have no disclosures. I'll start with an analogy. Imagine you get some imaging done of your liver and it looks like this. They find a tumor. The doctor says to you, we need a biopsy of this thing so we can figure out what it is and how to treat you. So you go to your biopsy and the physician blindly sticks a needle into your liver and takes a sample. They then repeat this process 11 more times, moving that needle to different parts of your liver, hoping that one of them is going to hit that tumor. That sounds kind of archaic, right? But the reason I'm telling you this is exactly how systematic prostate biopsies work. Your PSA is up or whatever, your urologist is concerned, you might have prostate cancer, so you get sent for a biopsy. We take 6 equally spaced samples through the right part of the prostate and then 6 equally spaced samples through the left, hoping that we hit a prostate cancer if it's there. More specifically, at least in London, this is done with the guidance of a transrectal ultrasound probe. So the probe is inserted into the rectum, butted up against the back of the prostate, and we take those 12 samples through the posterior aspect of said prostate. This is what the ultrasound images look like. That kind of blob at the bottom of the image is the prostate, and the vertical bright line is the needle going into the prostate. Unsurprisingly, this approach misses cancers, and you can miss it in a few different ways. For example, the tumor could be between your needle tracts, or it could be in front of your needles, which is particularly problematic if your prostate is big and the needle doesn't reach that far forward. Or you can just graze the edge of a tumor and therefore undergrade it when you send it off to pathology. You might ask yourself if this actually matters, and I will say yes, at least from an epidemiological standpoint it does, because prostate cancer is the 5th most common tumor or cancer in the country. Sorry, 5th most lethal, 4th most common, and number 1 in men. So at least from a statistical standpoint, if we have an issue with our biopsy of prostate cancer, it will lead to downstream problems for a number of individuals. And moreover, prostate biopsy is a critical part of the care pathway for prostate cancer, not only for diagnosis, but prostate cancer ranges from extremely unaggressive or indolent, even clinically insignificant, up to very aggressive. So treatment depends entirely on the results of that prostate biopsy. You might ask yourself at this point if you can even see prostate cancer, because if you can't, then that's the end of this talk. But of course you can, and you see it best with MRI. You can take my word for it that that arrow is pointing to a suspicious lesion in the prostate. More specifically, we use a range of pulse sequences to evaluate prostate cancer. I'm showing you the key ones here. And then we combine the findings on these images using a system called PIRADS 2.1 to ascribe each lesion in the prostate a number from 1 to 5. 1 and 2 are benign, so we don't really care about them, but 3, 4, and 5 are all increasing degrees of probability that that lesion is a tumor. How well does PIRADS 2.1 work? Well, I think you understand it best by looking at the graph at the bottom. So if you call something a PIRADS 3, then it has a 12% chance of being a clinically significant cancer. If you call it a 4, then that's a 60% chance. 5s are 83% chance. So not perfect, but pretty good. So that's fine. We can see the tumor with MR, but how do you actually target it? There are a few different approaches. The most direct, and apologies for this image for the mildly squeamish, but is an in-bore MR-guided prostate biopsy. The patient is put on their stomach, you insert a transrectal probe attached to this mechanism that allows you to make fine adjustments to the trajectory of the needle. You then slide the patient in and out of the scanner, localizing the tumor, and try to get that needle into the tumor under direct visualization with MR. So the images on the right there, you can see the needle sampling a suspicious lesion. Unsurprisingly, this approach is expensive, costing at least a couple $1,000 per patient. It's obviously uncomfortable, requiring sedation for most people, cumbersome for the provider. It takes at least 30 minutes, if not 60 minutes to do. And as we'll get into later in the talk, is probably not superior to other methods. So it will certainly not form the backbone of your prostate biopsy program, but I do want to make you aware it exists. Method number 2 is cognitive fusion, and that's actually very simple. You just look at the MR, try to figure out where the lesion is, and then when you're doing your transrectal ultrasound guided biopsy, you aim for that part of the prostate. It's non-trivial because the axis of acquisition through the MR is not aligned with the axis of insonation when you do a transrectal ultrasound. So some mental gymnastics and triangulation go into figuring out where the MR lesion is when you do your ultrasound, but it is possible. The advantages of this method is that it's quick, it uses existing infrastructure, so it's cheap, and sometimes when you know where to look on the ultrasound, you can actually see the lesion, and that is dead simple. On the other hand, you do need an operator who's able to kind of do these calculations in their head and figure it out. It doesn't make a formal record of the biopsy site, and when you can't see the lesion on ultrasound, particularly in big prostates with small lesions, it can be pretty tricky to know you're in the right area. Which brings me to method 3, software fusion. In this approach, you segment the prostate on your MRI and you segment the tumor, and then you register them together in real time when you're doing your ultrasound guided biopsy. That allows you to directly visualize where you're supposed to put your needle, and it makes a nice map of your biopsies afterwards. You can see in this case, they took 2 cores through a tumor and then did a systematic biopsy as well. The ultrasound probe can be freehand in its position detected by an electromagnetic field, or it can be attached to a robotic arm with sort of proprioceptive capabilities. And as an aside for a little trivia, this is an early prototype of one of the leaders in prostate biopsy systems with software fusion, and one of the developers was none other than our own Dr. Fenster out of Robarts. So a shout out to London on that one. The advantages of software fusion are that it is a little bit more idiot-proof than cognitive fusion, as it directs you to the lesion itself. It records the biopsy site, and you can use it for ablative focal therapies. However, you do need some new infrastructure if you don't already have this system. It is, of course, subject to registration error between the MR and the ultrasound, which can throw off your guidance. And it can be a little cumbersome, particularly if the robotic arm system gets in your way. A logical question might be, this sounds like a lot of work to do all this registration with MR. Can we just see this stuff on ultrasound alone and skip the MR entirely? Well, that was a question that the Cadmus trial tried to address. They took a bunch of men at risk of having prostate cancer, did both an MRI and a multiparametric ultrasound, including Doppler ultrasound, contrast ultrasound, ultrasound elastography, and regular B mode, and then targeted lesions that were found both with ultrasound MR and MR to see which one performed better. And in total, they had 257 patients, 83 cancers were found. Of those 83, 60 were detected with both MR and ultrasound, 6 were detected by ultrasound alone, but 17 by MR alone, which was better than the ultrasound. Moreover, if you look at the bottom figure, of all the men, 78% had lesions on MR, but almost 90% had lesions on ultrasound. The upshot of all that data is that ultrasound ended up detecting 4.3% less clinically significant cancers than MR, but resulted in 11% more biopsies. So there is some potential there, particularly in resource-limited settings without an MR, but it's certainly not a replacement. I hope I've made the case that an MR fusion biopsy makes sense, but I haven't actually showed you any data that is any better than systematic. So let's start with that. The PROMISE trial was one of the first big trials in this area. What they did was compared the ability of MR to identify prostate cancers. Note, they didn't do an MR fusion biopsy, just the imaging itself, and then compared that to just a systematic biopsy. Their gold standard was what's called a template prostate mapping biopsy, where they put this grid structure on the perineum and sample the prostate every 5 millimeters to get a really good sense of whether there's tumor in there or not. And what they found, unsurprisingly, was that MR was much more sensitive than was systematic biopsy for cancer, but a lot less specific. And their inference was that perhaps if you used MR as a guide for when to do biopsies or not, you might avoid 27% of biopsies in men who don't need it, and you might identify 18% more cancers. But as I said, they didn't actually try the fusion biopsy. So that limitation was assessed by Precision, another big trial by the same group, who just randomized men into getting fusion or systematic. In the fusion group, they found a cancer detection rate of 38% compared to only 26% in the standard group. And moreover, the detection of clinically insignificant cancers, which you don't actually want to find, was only 9% in the fusion group, but 22% in the non-fusion group. So by all protocol analysis methods, fusion beat out systematic. This was then supported by a Cochrane review of a lot of different studies coming to the same conclusion. So given the choice between fusion or systematic, you should choose fusion. But does that mean we don't need systematic at all, which would be kind of nice because that's 12 biopsies right there? Unfortunately, MR is not perfect, as I've alluded to. For example, in the PROMISE study, 44 men had prostate cancer that was not picked up by the MR at all. The MRI first trial addressed this issue by giving men both a fusion biopsy and a systematic biopsy. The cancer detection rate for systematic alone was about 30%, for targeted was about 32%, but when they combined them together, they were pushing 38%, which implies that both systematic and targeted biopsies find cancers that the other one doesn't, and therefore you should do both of them together. Paired CAP found similar results. They actually had men do a regular biopsy, cognitive fusion, and software fusion, which is a ton of biopsies. But if you look at the light-colored bars, that's cancer detection rate, and the highest bar is on the far right, where you combined fusion and systematic together. Therefore, again, supporting the idea you need both. Given the choice then between cognitive fusion, which is sort of easy to implement, and software fusion, which is a bit harder but a little more idiot-proof, which should you choose? Paired CAP, recall, had both cognitive and software fusion approaches. If you look at the cluster bars in the middle and the cluster bars on the right, those are the two approaches. In particular, the light bar on the far right is the cancer detection rate, not different between the two groups. The future trial randomized patients into in-bore MR-guided biopsy, cognitive fusion, or software fusion, and found the same cancer detection rate for all three cases. I will not bore you with this wall of text, but a subsequent meta-analysis of 43 studies with over 8,000 patients came to the same conclusion that it didn't matter whether you did an in-bore MR, cognitive fusion, or software fusion. The cancer detection rate was identical, or at least not statistically different. So take a breath, because that's been a lot of studies in a very short period of time. How have the guidelines used this information to tell doctors what we should be doing? I'll start with the European guidelines because they're laid out kind of nicely in a table, and I'll focus on a few. In particular, the recommendation for men who have never had a prostate biopsy before, but have a suspicion for having prostate cancer, is they get an MR before their biopsy. That's a strong recommendation. And then when they get their biopsy, you do a fusion and systematic if that MR is positive, which is exactly what we said before. Moreover, in men who've had a systematic biopsy already, which was negative, they also have a strong recommendation they should get an MR and use that to their advantage if they're going to be re-biopsied. The American guidelines are much more brief, but I will read what they say because they agree with the European ones. When a quality prostate MR is obtained, current evidence now supports its use in men at risk for harboring prostate cancer prior to the initial biopsy, as well as in men with an increasing PSA following an initial negative standard biopsy. So, given all that, what do we do in London right now? Last year, we did 696 transrectal prostate biopsies, which are only done at Joe's. We did 175 prostate MRIs, which up until recently were only at Joe's because our equipment was too old at UH and Vic to do a prostate MR, but now we can, which is nice. We do not have a software fusion system, so all fusion is done cognitively. But the main takeaway is currently only about 10 or 20% of the prostate biopsies we do have an MR or a fusion request beforehand, which is really far short of the mark of 100%. So with that in mind, I think our goal should be, number one, get an MR of these men before they have their biopsy so we can target a lesion if it's there. When a lesion is there, do a systematic and fusion biopsy. Consider investing in software solutions, particularly if we want to get into focal ablative therapies. Establish some kind of research focus in London that can set us apart from other centers. And in small text, because it's not really the point of this talk, but there is a global movement to move away from transrectal ultrasound guided biopsies to transperineal because it has a way lower risk of sepsis, unsurprisingly, because you're not going through the rectal wall. Let me finish with some cool new directions in prostate biopsy imaging. PSMA, or prostate-specific membrane antigen, is a radiotracer that quite specifically goes to prostate cancer. It's generally used in the setting of whole-body PET-CT to identify metastatic disease, but you can also image the prostate, like in this nice PET-MR, and use the uptake in the prostate itself to guide your needle. Some people have developed robotic prostate biopsy systems that can theoretically automate the process. I think this is like mildly terrifying, but it's nonetheless interesting. I wouldn't mind if this could do my job for me, but it does exist, so I thought it bears mentioning. What I think is potentially more interesting is microultrasound, which is a very high frequency ultrasound probe inserted transrectally with a resolution of 70 microns. You can see the beautiful delineation of prostate anatomy this kind of imaging can provide. But more of interest to us is that early studies have shown similar cancer detection rates to MR fusion. So this is potentially an avenue we could consider researching at London, particularly because the group that developed microultrasound is based in Toronto. I hope I've whet your appetite for all things prostate biopsy, and I'm sure you're eager to learn much, much more. So if you want to learn more, this is an excellent paper to get started. Here are a million more references if you want to take a deeper dive, and I'm happy to answer any questions. 17 minutes, wow, I rushed.